Good afternoon and welcome to our NHS West Yorkshire Integrated Care Board meeting here today in Brighouse. Thank you so much for everyone here in the room for joining us today and the preparations for today's meeting. And also thank you for people who've come to observe the meeting here in the room today as well as online. Today we're going to have a focus on secondary services, so that is particularly hearing from our West Yorkshire Association of Acute Trusts, as well as a update on maternity and neonatal services. We also will be hearing, having our first Freedom Speak Up Guardian report, which I'm really pleased to welcome, as well as our usual reports on the performance and the financial activity across all 5 places and our providers in West Yorkshire. Colleagues around the table have heard me say this many times before, but what we aim to do as an integrated care board is support the purpose and activities of our system and our West Yorkshire Health and Care Partnership, and that's particularly around reducing health inequalities, managing unwanted variation in care, using our collective resources wisely and ensuring value for money for the public purse, and also realising the wider benefits of health and care, including contributing to social and economic development. And I'm really pleased today that we are announcing out in public that as a partnership we will be the first Keep It Local integrated care system in England, and that's following our partnership board's approval of that on the 5th of March, and we'll hear later about that in our Deputy Chief Exec report. Before we get started on some of our usual business, I just wanted to go around the table so everyone can introduce themselves. We've got some people deputising today, and a warm welcome to them. And also for people watching in the room and online, so they know who you are. Keir, would you start us off, please? Thank you.
Hi, Keir Shilliker, Programme Director for Mental Health, Learning Disability and Autism, and deputising for Sarah Munro.
Hello, Tim Riley, Accountable Officer for the Leeds Place, and here representing Leeds.
Hi, I'm Karen Jackson. I am the Sector Lead for Community Services.
Hello, I'm Robin Tudden. I'm the Accountable Lead for Calderdale and the Chief Exec of Calderdale Council.
Good afternoon, I'm Nancy O'Neill, Chief Operating Officer, Bradford District and Craven, and I'm here in place of Mel Pickup, Accountable Officer for Bradford District and Craven.
Good afternoon, I'm Deborah Taylor-Tate and I'm Head of Planning and Performance for the ICB, and I'm here deputising for Anthony Keeley, Director of Planning and Performance.
Hello, I'm Heather Thrippleton, Associate Director for Health Watch across West Yorkshire, and I'm deputising for Hannah Davies today.
Hello, my name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB.
Afternoon, I'm Ranshu Chatterjee, Non-Exec Member for the BED.
Hi, I'm Stacey Fleming. I'm Governance Manager at the West Yorkshire ICB.
Hello, I'm Laura Ellis, Director of Corporate Affairs.
And I should have introduced myself earlier, but hello, my name's Cathy Elliott. I'm Chair of NHS West Yorkshire.
Hello, my name is Rob Webster. I'm Chief Executive of NHS West Yorkshire.
Hello, I'm Jonathan Webb. I'm Director of Finance and Deputy Chief Executive.
Hello, my name's Ian Holmes. I'm Director of Strategy and Partnerships and Deputy Chief Executive.
Good afternoon, everyone. I'm Majid Hussain, one of the non-exec members.
Good afternoon, everybody. I'm Brendan Brown. I'm the Chief Executive at Calderdale and Huddersfield Foundation Trust, and I'm the Acute Sector Representative on the board.
And hello, I'm Kate Sims. I'm the Director of People for West Yorkshire ICB.
Hi everyone, I'm Pip from Forum Central in Leeds, but I'm here deputising for Kim Shuttler. So she's a partner member of the board for the Voluntary Community and Social Enterprise.
Sorry, I thought that was off. Hello, I'm Carol McKenna. I'm the Place Lead for Kirklees.
And I'm Richard Vautry. I'm a GP from Leeds and the Primary Medical Services Partner Member.
Hi everyone, I'm James Thomas. I'm the Medical Director for the ICB and I'm also GP.
Good afternoon, I'm Becky Malby. I'm a non-executive member of the board.
Hello, my name's Ruth Unwin. I'm deputising for the Accountable Officer for Wakefield Place.
Hello everyone, my name is Fatima Khan Shah. I'm proud to be the West Yorkshire Inclusivity Champion, which is a role shared across local government and the Health and Care Partnership.
Hi, I'm Rachel Spencer-Henschel. I'm the Director of Public Health for Kirklees and I'm the Sector Lead for Public Health for the West Yorkshire ICB.
Thank you very much. And for anyone watching our board meeting for the first time, what you can hear is there's representation across all 5 of our places and also a variety of different sectors as well as services. And this is something we've tried to achieve over nearly 2 years of operation in making sure that we have a broad set of views across our partnership in supporting our work as NHS West Yorkshire. For anyone who wants to have a look at the documents that we're considering at the board meeting today, they're all available online. They're always available a week before the meeting, and you can see those item by item. Just to say, we have 2 items of any other business later on under item 25, and additional information came to the board on that yesterday. So I just want to note the apologies. You'll have heard around the table we've got a number of people deputising today, and I'm really pleased that we have deputies here to make sure that people's views and sectors are represented. Could you just take us through those quickly, please, Laura?
Yes, thank you. So we have apologies from Jo Webster and Ruth Unwin is deputising, Sarah Munro and Keisha Licker is deputising, Anthony Keeley and Deborah Taylor-Tate is deputising, Kim Shuttler and Pip Goff is deputising, Hannah Davis with Heather Thrippleton deputising, Mel Pickup with Nancy O'Neill deputising, and Tom Reardon. And we also have a number of other individuals who are arriving. So Jay Medley will be arriving shortly. Majid Hussain needs to leave at 4 o'clock, and Kate and Rachel will be leaving at 4:30. Thank you.
Great. Very efficiently done. Thank you. That's great. As a matter of business, we always ask at the beginning if anyone has got a declaration of interest in relation to today's agenda. Can I look round the table and ask? Brendan, then Ruth.
No conflict under any other business.
Great. Thank you. And Ruth?
I also have a conflict under any other business because of my interim role with Mid Yorkshire as Director of Corporate Governance there.
Great. Thank you. And that's in terms of financial planning for the system. Thank you. Okay, and just a reminder to everyone around the table, but also anyone watching this meeting, we have a live portal for declarations of interest, and people around the table, if you haven't updated it for a while, please do so. It's really helpful for us as a board in terms of good governance, as well as to be public accountable. Okay, we move on now to the next item, which is the minutes of our last meeting, which you remember we gathered together in Wakefield on the 16th of January, particularly looking at winter planning. Colleagues, is that a correct reflection of our meeting that day? I'm just looking around the table for hopefully some nods. People feel that's a good reflection. Thank you. We'll come back to matters arising in a moment. Laura, would you just take us through any key points from the action log, please?
Thank you. I think we've put updates for nearly all of those actions within the papers, so the majority are marked for closure with an update there to explain what we've done. I think there is just one open action, which was actually for Anthony and Sarah, neither of whom are with us today, and I don't have an update. I don't think we have one, so if we could leave that till next time, and we'll update them. Thank you.
Okay. I appreciate that. And also, Ian, if you would, I don't know if there's a moment now just to update on the work on primary care. We've had a number of focus on sessions on this as a board over the last 15 months. I don't know if you can give us an update now linked to the action log and then again in the Deputy Chief Exec's report, please.
Yeah, thanks, Cathy. So we provide a bit of an update in the Deputy Chief Exec's report, and the headline in relation to primary care access recovery is that we continue to make good progress, I would say. So all places are ahead of trajectory in terms of additional appointments. We're making good progress in terms of additional roles, 1,358 across West Yorkshire. Places have adopted the RCGP joint standards for supporting the primary secondary care interface work, which is something we discussed in November. And we are taking forward the work around Pharmacy First following sort of national guidance on that around Christmas time. I guess the other thing we took away from the November board is that doing more on primary care and more of the same isn't just the answer to this. And there was a request for sort of a bit of a blueprint for radical change in primary care. So we're doing that work now. We started engaging in conversations with clinical directors on that last week. And the plan will be to bring something back to the June board that sets that out. We also had a roundtable with Richard Meddings, the chair of NHS England, focused on primary care a month ago, and we've included a short write-up of that. Was really helpful discussion in the Deputy Chief Exec's report. The final thing I'll say on primary care while I've got the floor, Chair, is that we continue to deliver in line with the dental investment plan we talked about last May. So we talked about spending the additional £6.5 million to support improvements in dental services, and that has progressed well over the year, I would say, including more access to urgent dental sessions, providing additional sessions for children in deprived communities, for asylum seekers and for homeless populations, working with local authorities around prevention initiatives. And the other thing that we've done that I'm really pleased about is that we've built capacity in the dental commissioning team, as we agreed last spring. So that's now up to full complement as well. So it's still a really challenging context in all primary care, and particularly dental, but I think we're making good progress based on the points of agreement last year.
Thank you very much, Ian. That's really helpful. What I'd ask is there's a number of people around the table, including Richard, representing primary care on this board, Becky Mulby is our Quality Committee Chair, Carol, who's working alongside you, and a number of other colleagues, just to have that input before that June meeting as well. And we're going to forward on that write-up, aren't we, to the NHS England Chair for consideration. OK, great. Thank you. We'll move on now to public questions. As you know, through our West Yorkshire Health and Care Partnership and through this board as NHS West Yorkshire, we invite questions from members of the public on the agenda of the day, and that's another reason why we make sure that the papers for the meeting are out a week before. So we have one question we've received today, so I'm going to hand over to Laura to read it out, and I think Brendan, on behalf of the acute sector, is going to respond on that.
Thank you. So yes, we've received one question from a member of the public, Georgina, and the question is, what measures are being undertaken through WIAT, so the West Yorkshire Association of Acute Trusts, to improve the efficiency, accessibility and equity of neurology services? And I'll pass to Brendan. Thank you.
Okay, so I think it's a great question, because this is an area where we recognise that there are challenges in our service provision, which reflects the national picture around neurology services, and those challenges are driven by a shortage in the medical workforce and a growing demand for services. So across the West Yorkshire Association of Acute Trusts, we set up a programme of work which is clinically led in 2023, recognising that there is variation in access to these services. Whilst I've talked about that being clinically led, the clinically led element to this service includes our medical colleagues, our nursing, allied health professional and operational colleagues. It is truly a multidisciplinary approach to all of this. Our short-term response is to put in place input from clinicians from Leeds Teaching Hospital and Mid Yorks Teaching Hospital into services at Calderdale and Huddersfield to ensure that there is access to neurology services across Kirklees and Calderdale. And there are a number of work streams within this programme of work which includes specific pathways for patients with multiple sclerosis, epilepsy, Parkinson's and motor neurons disease. There is an initial focus on people with a learning disability, as we recognise that there is an overlap, often in clinical lead, and we are paying attention to the inequities and health inequalities that specific communities can experience. We're also proactively speaking with a wider range of voluntary sector organisations and patients groups to ensure that this programme of work is truly co-produced, especially around our condition-specific pathways. As an example, we've recently met with the Motor Neurons Disease Association and are collaborating with the new Rob Burrows Centre for M&D about how we can support patients across the whole of West Yorkshire. So model is in development, initial work has taken place. I have a much fuller and much longer response which I will share, and I am aware that our colleague has met with this lady who's asking the question in both a professional and a personal capacity, and I think we'll be offering a further follow-up conversation. This is an ongoing piece of work.
Brendan, thank you very much. And as usual, we'll provide a written response to the person who asked the question, as well as we will put that on our website afterwards, as we do for this board, as well as we do when people ask questions from the public to our partnership board. Brendan, thank you very much for that. OK, and just a reminder, there are lots of different ways in which you can engage with NHS West Yorkshire and our work across 5 places, as well as our provider trust. There's lots on our website. There's some examples in my chair's report today, and that includes West Yorkshire Voice Forum as well. So anyone that hasn't become a member of that, perhaps if you're a governor within an NHS trust or member of a patient group, please look that up and sign up. Okay, so we now move on to our focus on acute services today. This is the last focus on topic in this series of board meetings. As board members will know, we have spent around 12 to 15 months or so visiting different services and sectors, and I'm really grateful to Brendan and Lucy and other colleagues, Russell and Simon, for supporting bringing this report together, and to Heather and Hannah for bringing the Health Watch Insight report to complement it. Brendan, we talked openly about finding the right time to come to the board. I think people might say, why is it coming now, as one of the last topics, but it was also respecting what was going on for acute services and secondary care during the winter period. So thank you for the preparation. As colleagues around the table know, but for anyone watching, we'll now spend around 45 minutes or so looking at this. It's sort of like a deep dive to look at the services, particularly acute services 5-year strategy. And Brendan, I'll hand over to you to introduce your colleagues and to give us an overview and some points for discussion for the board. Thank you.
Thank you, Chair. I might ask my colleagues to introduce themselves. This is a friendly board.
Am I pressing the right button here? Yeah, I'm on. Lucy Cole, I'm the Wyatt Director.
I'm Russell Nightingale, I'm the Chief Operating Officer in Harrogate, and I run the elective care programme for West Yorkshire.
And we are expecting another colleague. We are a little early, so Simon Worthington, who is the Finance Director at Leeds Teaching Hospital and the place-based finance lead across Leeds, will be joining us shortly. Okay, so thank you for asking us to give a presentation and a focus on what we're doing in the acute sector. I think, as Cathy alluded to, we were asked to do this in January, which I did make a plea to, could we move it? We were a bit busy in January, as it was the winter. But what we're going to talk to you about today is who we are, what we are, how we do things, what our strategy is going forward. We're going to talk about our people. We are only successful through the people that we work with, how we're looking at the productivity and spend challenges that we are all facing, and then where do we want to go going forward, speaking to the 10 ambitions across West Yorkshire, but also about how do we truly innovate acute services. We will allude to how we work with the other provider collaboratives in the room and across West Yorkshire. Just to say who we are the 6 provider trusts across West Yorkshire, 4 of which are also integrated trusts. We work alongside around 50,000 colleagues. And it's those 50,000 colleagues who are caring for patients, either at a patient-facing level or behind the scenes, day in and day out. And I have to say, do a pretty phenomenal job. That means we have a turnover collectively across those 6 trusts of 4.1 billion. And we serve a population of just over 2.7 million, which I understand is the size of Jamaica. I think just to call it out, so Lucy and I did a little bit of research about who we're comparing ourselves to, and that's it. So I think it's also important to just call out, when you look at provider collaboratives across the country, they're probably much more condensed than Wyatt is. We serve a huge geographic population. We serve across West Yorkshire, and I think that plays into how we do things slightly differently. So at this point, I'm going to hand over to Lucy.
Thanks very much, Brendan. I have got some slides, but I don't think we need them. I'm quite happy to share them at the end, though, if you want to publish them with the paper. So I think what I thought I'd do first is you've got a paper. What we're going to try and do is bring that to life a little bit and talk about, under the focused headings of our strategy, some of the work that we do and some of the benefit to the kind of population of West Yorkshire of us working together in that way. So just a little bit of sort of potted history is building on what Brendan said already. It is why, as a collaboration, I think that word's really important. It is a collaboration rather than a separate organisation. So this is a collaborative of the 6 trusts, acute trusts in West Yorkshire, and as Brendan said, 4 of those are integrated providers of community services. It is a forum for those trusts to come together to share issues on what's happening in secondary care services and find opportunities to work together. I think crucially, from the inception of Wyatt back in 2016, it's been very steadfast in its kind of purpose, which is around tackling unwarranted variation, which we know still exists, whether that be in access, outcomes or experience. And the focus on that is really how can we work together, how can we identify that variation in an open and transparent way and work to address that. We've been focused on the delivery of a number of acute sort of change and transformation programmes over those intervening years since 2016. And more recently, we've seen kind of taking that leadership role on behalf of the system on things like planned care, diagnostics, which are much more sort of cross-sector collaborations. So not just about what happens in the acute sector, but what happens across whole pathways. Equally, there are opportunities for us to work together, and we've been working with the Mental Health Collaborative on a number of programmes in relation to how we deliver services for people with mental health issues coming into secondary acute care, and equally how we support the physical health needs of people that are in mental health, learning disability and autism services. What we saw, I think, during the pandemic was that actually there was an acceleration, not just from programmes of work, but actually into the day-to-day. How can we support each other and provide, I don't particularly like the phrase mutual aid, but it gets used a lot. How can we provide that peer support to continue to deliver services? Brendan's just alluded to that around neurology, but equally there are a number of services where we've seen cross-sector and cross-hospital support to continue to provide services in local places. We kind of have worked together on trying to prioritise where we need to invest in the system. So community diagnostic centres, surgical hubs, where can we get the best from the assets available to us in West Yorkshire in order that that benefits our patients and populations. And just again to focus on why it isn't sort of the HQ of those 6 organisations, why it is only the things that we do together. So I think really important just to set some of that context. So as I said, what we'd like to do today is talk to you a bit about our strategy. So I mentioned why it's been around since 2016, but we've never really purposefully set out a strategy. And the reason we felt it was the right time to do it now was obviously everybody in this room and people watching will be aware of the drivers around population changes, health inequalities, the kind of recovery post-pandemic, but equally in terms of the financial challenges that we're seeing, but opportunities around research, innovation, new medicines, technology. And equally, kind of the partnerships that have kind of emerged. So we've worked together well as places in West Yorkshire for a number of years, but the ICB becoming a statutory body, it felt like the right time for us to say, here's what the Wyatt contribution can continue to be for the people of West Yorkshire. So our strategy is shaped around kind of 6 key pillars. We're going to talk to those sort of between us and just try and give you a bit of a flavour of some of the work that we've done and equally some of the work that we plan to do. So Russell, I'm going to hand to you first to talk a bit about kind of the way we do service delivery and the way we work together.
Yes, thanks, Lucy. So you'll see in the slide deck, which we'll send around afterwards, but there's 3 strands to our service delivery, and it's primarily tactical, transformational, and then strategic. So our tactical is the kind of the day-to-day running, making sure services are operating and running effectively. So back to the neurology question previously. So things like non-surgical oncology has been a pressure for us across the 6 sites, recruitment issues, attracting people into sort of smaller hospitals to provide some of that service. So we've been working over that over the last couple of years to ensure there's a model of delivery at all sites, but hosted by two main providers. The things on our radar short term are neurology, which was mentioned, and also sort of head and neck surgery as well is something we're working on. We embrace those challenges as a collective group of acutes to never waste a good crisis, to make sure we can try and get service delivery that's right for patients and right for the future in the crisis we faced. We've got collective use of capacity, so something we've been working on, and certainly in the elective sphere over the last 2.5 years is, we have groups around all of our main objectives as hospitals that's Chief Operating Officer title and Chief Exec SRO. So when we work on some of those elements, but the tactical part sort of phases sometimes into that more kind of transformational. So who's doing what well, and how can we learn from each other? So for us, primarily, we look at model system. We use lots of sort of reported data to see who's the best at something, and then we go out and we visit those sites to pull some of that learning back in. We've done some really great shared models of learning around theatres and people that manage to recruit into theatres. People have the best capital utilisation, such as Airedale, and we've all schlepped to Airedale to have a look at what they're doing, and some really fantastic work. Then when we move to sort of that strategic, it's new service models. So do we all need to be providing the same things at the same areas? Is that what the patient demand is required? So when we have some spare capacity, not doing the day-to-day, we look at the sort of strategic element around the future and who can provide what where, and what makes best use of the money, but also of our capital and people as well. So those arms that we've set up, there's a weekly cadence, quarterly face-to-face, and that's where we kind of drew the delivery. As Lucy said, we're a collective of people that have time and respect for each other, patients at the forefront of all of our decision making, and what it means is that we can all work together across our 6 organisations, which gives us more sort of operating power between us, which I think is just fantastic. How about you, Lucy?
Thanks, Russell. I'm just going to hand to Brendan to talk to us a bit about workforce.
So, as I alluded to, we're only going to be successful through the people that we work with, and there's 50,000 people working across Wyatt. That's a significant amount of people, and many of you will have already been in touch with them, and you will have been inspired by their passion, their innovation, and their commitment to the work that they're doing all day, every day. And if I think about the 3 things that we think about around our workforce, workforce is often described as an opportunity or a challenge. Well, we all know that the workforce picture across the country is challenged, but actually we see our workforce as a real opportunity. And how do we, as Russell said, empower them? Because they have the ideas and the motivation and the wherewithal, if we lead them in the right way, to actually lead services and transform them. So the 3 things we think about around our workforce are about how do we share our knowledge, what's our collaborative planning around the workforce planning dynamic that we've all been involved in for years, and how do we truly collaborate on delivery. So I think our colleagues would be able to talk to you about the best practice that we share around recruitment, retention, the new role development and the training initiatives. We think about, I talked briefly about neurology services in response to a member of the public's question, but there are other challenge services across the country and indeed in West Yorkshire. But we're facing into that because that is the reality of the climate that we're all operating in. And traditional ways of working will not, in our collective opinion, see a way out of this. So how do we empower our workforce to go with the ideas that they've got about working differently with different models of care and different opportunities, but equally to think about using their clinical expertise to drive a different way of working. You'd think I probably should have introduced the 6 organisations that are Wyatt, but I'd hope you know they are Leeds Teaching Hospital, Harrogate, Calderdale and Huddersfield Foundation Trust, Mid Yorks, Bradford Teaching Hospitals and Airedale. And you'll see I've seamlessly paired those up into, we're not just a conglomerate of 6 that work constantly together. We also pair up due to our geography and due to the commonality of the challenges that we're seeing. So to that point, there is a collective design around our workforce for those shared priorities and how do we do things around such the non-surgical oncology elements of care. And you will know, as we've talked about here before, the work that's taken place between my organisation and Mid Yorkshire and what we've termed as the South sector, and what the work that's taken place in the North in response to the West Yorkshire picture around non-surgical oncology, which mirrors the national picture around the challenges those services are facing. You'll know that we've already reconfigured vascular services. That was one of the first things that we did. And the reconfiguration of services and the future configuration of services isn't easy. This is about how do we plan for a different model of care, taking into account some of the inequalities and the access issues that we know we are faced with. We're thinking about what do we do now, what do we do in 5 years, what do we do in 10, and what do we do in 15 years' time, without making anything worse for the communities that we are serving. And again, I think it speaks to the greater geography that we see. And I'm really clear, and I'll say this repeatedly, our workforce are our community are our workforce. Across West Yorkshire, we work with people who live and breathe in our communities. We want them to live well and work well. We want to give them the best opportunity that they can. And to think about our collective delivery, one of the things we've done recently, and it was a successful punt, I would say, we started our own development programme for our leaders across the 6 organisations. Because what we felt was there are several national programmes, but what we wanted to test out was how do we develop our people to work as system leaders, as we all are around the table. And if we're going to do that, we needed to invest in them and do something differently. So we did it. It worked well. We had, thankfully, contribution from around this table. And what we'll be doing this year is repeating that programme. It starts in April, but with our community colleagues from the Community Collaborative and our colleagues from the Mental Health Collaborative, Because what we think is osmotically there will be a greater fertilisation of thinking by having people together. And equally our YAS colleagues are joining that. So it speaks to what I've talked about. How do we invest in our people? I think the next chief execs and chief officers, not all of us will be here forever, will we? We're all of a certain age. But those next chief officers are in our community. How do we embrace them and develop them and give them the best starting chance? They may start in one sector, but they may end up leading in another. So I think that's probably it for workforce. As I've said, I could go on all afternoon, as my colleague to my left would say, about our people. We could spend the whole agenda on this, but we are only successful through our people. And I know some of the national conversation currently is about, do we need to look at the headcount of our people? Do we need to look at what they're doing? I think we need to carry on investing in our people and giving them, as I've said, the best opportunity to be the best that they can be, because that's what will make us all successful and truly serve the communities who deserve better. I might go back to you, Lucy.
Yeah, it's me again. So you are going to hear from me for a little bit now. And apologies, there's been a bit of a miscommunication with Simon over physical and virtual presence. So I'm going to channel my inner Simon, imagine somebody much, much taller and much cleverer. So I'm going to talk about the third pillar of our strategy, which is around productivity and efficiency. And this has kind of been at the core of what we've been doing for a long time. So I mentioned unwarranted variation. Cost is as much of a factor in that. And everybody around this table is fully aware of the financial challenges that we face this year and that we're going into in 24-25. And I'll kind of split this into three parts. So the first part is around how do we do that sort of collective planning and opportunity identification? So I think really importantly to this is that kind of transparency and open book approach in terms of where we are, what's driving cost in our organisations. And as Russell mentioned, we've got loads of benchmarking data. We're really fortunate in the acute sector as compared to other sectors in terms of that benchmarking data that's available. And what we've done with that is generated a 5-year efficiency strategy, and that's told us what Simon would term as a big number that is an opportunity for us in terms of driving out further productivity and efficiencies in the way we run our services. And that's through comparing ourselves not only to each other but equally to those best performers nationally to see what the opportunity might be. If Simon was here, he would also say not all of that is completely realisable, if that's a word, but what it does is points us in the direction of where to look. And where to look kind of can come in two forms. Either we can drive that through our own organisations, learning from each other, and you'll know from conversations through this board that actually the trusts have delivered record levels of waste reduction and cost improvement in the last financial year. And part of that is through sharing the good practice that's happened within organisations. And equally, everybody's really committed in terms of using improvement methodologies. So this really is about waste reduction rather than kind of what we might have termed cost improvement in old money. Everybody has a slightly different approach into how we use those improvement methodologies, but we don't need to be unified. They're all of the same spirit, and it's all about trying to identify those bits of pathways that don't add value, those systems and processes that don't quite work, where we become more efficient and therefore cost effective. And then in terms of collaborative delivery, there are the opportunities where we can do things at scale. So we've got really great practice in some of the organisations around robotic process automation, effectively using bots to do kind of manual processes otherwise done by humans. We're working together to develop a business case effectively to understand how we might be able to deploy that across all 6 organisations. So effectively scaling up that skill and those processes across each of the 6 trusts. Joint procurement is a great example of whereby we secure greater value for money, greater value for the public bound by working together. So recent large-scale procurement we estimated we probably saved about 5% more by working together than we would have done if we'd undertaken that as a separate process. And that doesn't factor in the kind of the cost of the multiple exercises and human time that would go into running those. Productivity is obviously a big focus, so everybody will be really aware of the kind of big headlines around NHS productivity. I think the work that we've done in Wyatt has been nationally influential in trying to debunk some of the myths around that. So I think there is a kind of transition from 2019-20, which is the baseline everybody uses in productivity terms as pre-pandemic. In terms of the changes we've made to pathways, which are better for patients, but the changes in coding perhaps don't lend itself to doing us any favours in what looks like productivity terms. So I think we've done a lot of work to kind of get underneath where is there a true productivity opportunity, and there absolutely is one, but it's not anywhere near that kind of big publicised 20-25% headline. And I think really importantly, and hopefully Jonathan will agree with me on this, that this is a system focus as well. So this isn't about us just doing this in the acutes, but equally where are there opportunities that we can work across with the ICB and with other providers. So actually where we're identifying opportunities, as we have been very recently, does some of that apply to more of us than just in the acute sector? And just to say as well, we're not insular in that approach. So we know that a number of systems have had to go into sort of turnaround approaches given the financial challenges. We've been learning from them. We've been speaking to all of those systems to understand where they've identified there are things that can be done collaboratively that perhaps we're not doing, and asking ourselves some hard questions around, have we not done it because it's on the too difficult pile, or have we not done it for good reason? And that's all about that warranted versus unwarranted variation. So very much a focus for us over the next 5 years. Already some quite detailed plans in place in terms of how we're looking to achieve some of those efficiencies. So I'll just move on then and talk about two more of the pillars of the strategy, and then I'll hand over to Brendan just to do the final piece, which is more about our approach. So the penultimate one is around infrastructure. So I think recognising, as Brendan said, our people are a huge asset to us, but equally our estate and our digital infrastructure is vital in terms of providing sustainable services into the future. And again, I think we can think about our infrastructure and how we work together in three ways. The first is sharing knowledge. So there are some, again, nationally published benchmarks through Lord Carter's work around underutilised space turned over to non-clinical services, and there are some kind of best in practice levels we can get to, and we're supporting each other to help us get to all of those within our organisations. And equally, there are different initiatives where we're at different stages in the journey. So electronic patient record implementation, we've got some organisations that are much further ahead in that journey, and some are just going through those implementations. So how are we sharing that knowledge? You know, Airedale are working through their EPR implementation at the moment. They're having good conversations with Bradford and with Calderdale and Huddersfield colleagues around what's the impact going to be on our capacity? How long will that last? What do we need to do? What are the mitigations we can put in place to support us through that? The second area is around collaborative planning, and I alluded to this at the start. So where can we make that case for investment in sort of basic digital and estate infrastructure, and really sort of making sure that we're waving the flag in terms of the criticality of some of this. So I think capital, I know, has been a conversation around this board numerous times, and the constrained capital environment we're operating in. There are, in terms of backlog maintenance, there is significant work to do in all of our sites, and we've got a number of kind of mixed estate, and some of that older estate really still needs to have significant investment just to keep running the services it's running now. And then I think really importantly is thinking about where collective assets can serve the population. So one of the big schemes we're working on at the moment is a single aseptics hub. So this is about the aseptic preparation of particular medications. We'll do that largely from a single site in Leeds, supported by the site in Bradford. And that will provide aseptic products to hospitals across West Yorkshire and Harrogate. And what that means is those nurses on the wards no longer need to do that preparation, and so it releases their time to care. And that's just one example of how we can use a collective asset in order to work differently. Another example I would cite in the digital space, we were fortunate to obtain capital funding for a single laboratory information management system. This is really critical to us being able to configure some of our pathology services differently, and in doing so being more efficient, more effective, and ensuring that we've got consistency in turnaround times and quality and results that are going back to clinicians and then on to patients. What I would say is being a collaborative has served us well in that respect. We've had over £70 million of investment in collaborative schemes as a result of being able to demonstrate that we can work together, do things once and obtain best value for money. So I think it's really important to recognise that we perhaps wouldn't have been in that position if we tried to undertake those as separate organisations. And then finally, one area I wanted to talk to you about, which is a sort of fifth pillar of our strategy, and this is a new space for us, is around research and innovation particularly. And I think we recognise that we've got some amazing research assets. We've got incredible academic institutions in West Yorkshire. And perhaps in the past it's been a bit fragmented, so there are relationships between particular institutions and bodies and particular trusts. And there are opportunities by working together that we can make the best of the infrastructure that already exists, but equally the offer, as Brendan says, of 50,000 people who work in those organisations with different skills, experience and research interests. Equally, we have a broad population with a great demographic, different communities, whereby it makes us a great test bed for working in the research space. And I think our focus, I'm going to break this down to 3 areas. The first is around what in the research world they would term as discovery. So how do we do the best research in West Yorkshire, and how do we, as a community of NHS providers, inform that research? So we're talking about the reality of what we're seeing in patients, and how are those research questions and problem statements being fed in to our kind of academic and research partners, and ensuring that any developments in that space are driven by the need that we're seeing in terms of population health changes. The second part of this, and this is where I think we can really add value as an acute sector, is around that kind of test piece. So we, as Brendan said, cover a population of 2.7 million. We've got over 50,000 employees. The opportunity there to take some of that research or take new innovations and take them into that real life space and test that and learn from it and feed that back and iterate it is really, really strong. Russell's mentioned some of our clinical networks. I think there's a question for us there and something to do in terms of how do we connect the sort of clinical academia with the clinicians on the ground in terms of bringing them together, finding new opportunity and finding ways to test and learn from that. And then finally, that kind of how do we take that from test then into impact, real world impact? So how do we take what we've tested, learned from that, into something of a scale that's going to change things for the population of West Yorkshire in the way that they receive their care and the outcomes they receive from it. So something we're really excited about. We think there's huge opportunity to work with a whole range of partners in this space, but we think that it could have some real benefits. And I was hoping to get the figure. I think I was quoted in terms of the research income that Greater Manchester pulls in kind of far outweighs what we do in West Yorkshire, and we think that's a gap that we really need to close because we've got an equally deserving population and group of clinicians that are willing and able to utilise that. So finally, I'm going to shut up for a minute and I'm just going to ask Brendan to talk about our final pillar, which is around ways of working, which is much more about our kind of collaborative approach in how we deliver things.
Okay, home stretch. So thank you. As Lucy said, how do we work? Well, I'd hope that you would see us as an anchor partner rather than just a collaborative. We are obviously committed to the work that we're doing with our patients from an acute sector perspective, but we're also interested in the broader lives of our people, the broader lives of our patients, their housing, their education, their experience living in West Yorkshire. And we have a role to play in that. We're all living in a fiscal environment that is incredibly challenging. So it speaks to what role are we playing in those conversations. And just to be frank, please don't think that we're all sitting around in a dark room singing Kumbaya. That's not how it works. So we work with authenticity. And what Russell has described as cadence, there is a rhythm, grip, a battle rhythm to what we do. We face into the problems that we're facing, and we look at that collectively. All 6 organisations are working in the same space or at the same level, so there are conversations constantly about how do we do the best thing collectively, or how do we help one another out. I think we all know that we've lived through a pandemic, and our chief operating officers, I think, are a great example of stepping into the breach and thinking, but Lucy referred to mutual aid. Actually, we just did the right thing for the right reason to get the right result. But collaboration is absolutely at the heart of what we do. We've worked on a memorandum of understanding which has served us well and will continue to serve us well. And we pay attention to our leadership. We pay attention to our behaviours, to our conversation, and to how one another is performing. So the principles of that are that we do support primacy of place and subsidiarity. Conscious we're in a public board, but we're not like other systems where we're looking for either a land grab or to take control of the money. That's not how we work. We're much more committed to why do we do the right thing, by our patients and work in partnership. We work because we are truly a peer collaboration and a collaboration of the wanting. We have the networks that Lucy's described, and that speaks to how do we give people opportunity to lead beyond their portfolio. If Mel Pickup was here, she would talk about if you are successful in gaining an executive position across Wyatt, you don't just work for your organisation, you work across West Yorkshire. That's what comes with the territory. I don't think that just sits at executive level. I think that speaks to our senior managers. And I would also say that many of our clinical workforce have been working collaboratively for years, before the term collaborative was sexy or in vogue. They've just been doing it. We've tried to help them take that to another level. And as I said, it works because it's a collaboration of the want. It's a true collaboration. There is a levelling of authority and decision-making and challenge. It's supported by our shared information, benchmarking, insights, data, peer learning. You know, we have regular visits, as you would expect from national colleagues, such as Professor Tim Briggs, to talk about the Getting It Right First Time programme and how do we reduce variation. He likes how we work in West Yorkshire. He can see the impact and the results, and other systems have worked with us and visitors to see what we can do. We don't take any of that for granted, though. We're not sat here saying we know what we're doing, we're getting it right all of the time. That's why we want to work and influence at a national level. We have several transformation programmes in train. We pay attention to that. I think, as I described perhaps earlier in some of the conversation in our private board, and we might pick up further in the discussion today, the world that we live in is harder. It's more complex. The NHS model that was originally set up has obviously changed based on the needs of the communities that we serve. And again, we're facing into that conversation to think about what is the operating model that we need to lead through West Yorkshire, what will that look like, and how do we future-proof it for future generations of both the workforce and our communities. I think it's important that we continue to demonstrate nationally what our model can do. As I've said, it's arguably bureaucratically light, and there is a reason for that. It's so that we can get stuff done. You will have seen in much of the NHS press conversations about governance or accountability. That will slow us down. That's why we are influencing and continuing to talk to national leaders about what a successful collaboration could look like. And we have examples, as Lucy's called out, of how we do that. Getting a reconfigured vascular service, an aseptic unit in Leeds, a different non-surgical oncology model is no easy feat. This takes time, in and above everything else that everybody's doing around their very challenged and busy day jobs. And we also, as I've said, want to continue to share best practice to bring together that forum of collaboration, innovative thinking, and challenging that unwarranted variation in access, outcomes and experience. We know that we are challenged in this area in the same way that the rest of the country is, but as I've said, we're facing into that to get something sorted around that. So we will continue to influence national policy agenda and structural change. Wherever there's a conversation about what this could look like, we are there with our hand up saying, yes, we know that's what the think tank may be saying, but this is how you could do it. Have a look at this and see how it works. And we will continue to invest in what we consider to be the right model of leadership, which is dispersed and empowered. And as I've said, you will have come across many of what we term as senior responsible officers in leading specific projects. It works, and it works for a reason. So I think am I finishing now? I'm looking to Lucy to say, am I finished now?
I was
going
to say a small thing, Brendan, but you've kind of said most of what I was going to say. So I think all I would end with is hopefully we've sort of given a bit of a flavour of how Wyatt works. I think there are some things, as Brendan's just mentioned, that we can absolutely point to, which are differences in the way that we work, in differences to how the population is served and the outcomes as a result, and hopefully given an idea of the continued direction of travel. So what I would say about the strategy is it absolutely aligns to the integrated care strategy purposely for West Yorkshire. Equally, it's about a consolidation of what we've already done. So it's a building on of rather than, so people would say evolution rather than revolution. But hopefully you've kind of also got the flavour that we're continuing to be ambitious, that we want to strive to do new things and find those opportunities for collaborative working that haven't yet been touched. Thank you.
Great. Thank you very much. Brendan, Lucy, Russell, really appreciate your time today, preparation for the report and the presentation, which is really welcome. Thank you. Before I open it up to questions, though, I'm starting to note people's hands up as they're coming through. I wanted to invite Heather just to share the Health Watch Insight Report. If you remember when we looked at winter planning and delivery at our last board meeting, we then contrasted or complemented that report with Health Watch Insights. I'm going to hand over to Heather and then I'll start noting hands up that are starting to come through. Thank you.
Thank you. And first, it's just really great to hear positive impact of that collaboration and the impact that's having on access, experience and outcomes for people. So the briefing paper that we've provided today summarises insights from local health watch across West Yorkshire, but more specifically insights captured via West Yorkshire Voice. We asked people about their experience of hospital care, but also waiting for hospital care. And really positively, over 50% of people that responded to us reported having a good experience, which is really good to hear. We also heard examples that echo those examples given in the previous paper. By the collaborative, where people's waiting times had been minimal with really efficient treatment pathways, and this was particularly a theme for cancer treatment patients. Across the board, we heard 5 key themes. The first we describe as the 3 C's, and what we hear consistently from people about what would make a really good experience for the people of West Yorkshire. So they are communication, compassion and coordination. And we also heard about waiting times and hospital discharge. For each of the themes, obviously there were good experiences, and particularly to highlight what we heard about positive experiences with staff. So those who experience kindness and compassion, and how crucial that is to someone having a good experience. So just particularly wanted to highlight that because we know staff are working really hard. However, we did also hear from people when things haven't gone well, and some of those examples were around when communication has been very poor, lack of information being shared, lack of consistency in clinicians providing treatment, systems not working together or being joined up, administrative errors leading to further delays in treatment, long waits for getting an appointment, but also when at appointments waiting to be seen, and a need for more person-centred discharge planning. We also heard from quite a few people who have had to travel to appointments, so often out of their local place area, travelling long distances, sometimes not on public transport routes as well, so thinking about kind of equity and inequalities and making sure that people have equal access. And I suppose you talk about the aseptic. Yes. So I suppose just the thinking when we're delivering something in a particular place that we're considering that everyone's going to have equal access to get there, and how we build that into our planning. So within the paper we do make some clear recommendations for each of those 5 key themes. I think we say this every time, but communication needs to be clear and accessible. People would like regular updates on their treatment, and given a contact number or point of contact where possible, so that if people do have questions, it's really straightforward for them to ask, and that would also kind of cut down any traffic that might be going through to other numbers or other means of communication. People often just want to know that they're still on the list when it's been a long period of time. Better coordination, so joined up access and processes, joined up systems, notes being transferable, etc. People given a choice of treatment locations where possible, and given plenty of notice in advance, and information provided with what that treatment might be and how that might look for each individual. And we recommend that staff continue to be supported to deliver that compassionate care, whilst working in what is a very pressured system. Again, regular updates on waiting times, information should be shared on how people can look after themselves during those periods, so making sure that when people do have a long wait, we're signposting to where support can be found, or kind of linking people into other options while they're waiting to keep themselves well. And that people are at the centre of discharge planning, with discharge plans clearly in place well in advance of discharge, again where possible. And these plans should be made with people, and particularly with their families and carers, and they should be involved as soon as possible in that process. Thank you.
Heather, thank you very much. I know you've been involved in putting that report together. It's available online, so members of the public can see that. And I just want to invite Brendan to respond on that. But thank you for those insights that complement a lot of what Lucy, Russell and Brendan have shared, as well as I know brings other experiences for them to consider.
Thanks, Heather. I thought it was a great report, and thank you for your comments. I think your points are well made. In and amongst the constitutional standards that we all are expected to meet, because for the right reason, there are patients in and amongst this. So we talk about a discharge as a discharge, but actually it's a discharge of a patient that may be going back into a difficult situation. So these are the things that we are paying attention to across each of our organisations, who are under varying degrees of pressure. I think we still talk about winter pressures, but it's all year-round pressure now. But again, I would argue that Russell and Lucy will back me on this. It is about why it is focused on what we need to do for our patients and what we need to do for our communities. And, you know, what one size will not fit all. That is the reality of all of this. I think you made an important point about communication. It's easy to think that Wyatt's made up of doctors, nurses and allied health professions. But actually in your conversation there about elective recovery, I was thinking about the outstanding medical secretaries that we've got that maintain regular contact, obviously not all of the time, but for the most part with our patients who are waiting for surgery. It's not about the target, it's about who's keeping them informed and who's making contact with them to check out what their risk or their experience is and how do we work with primary care in those conversations. We've got some stellar colleagues who do that piece of work. And then your point's absolutely well made. This is the thing that we're paying attention to. If I think about the non-surgical oncology reconfiguration, we need to think about the travel experience for patients, but the travel experience for unwell patients and for their families who will be concerned and anxious. It's what do we do around that? And perhaps just before we open to questions, can I ask that you all ask Russell questions? Because he's actually coming off his holiday today. We need to feel this is worthwhile for him, but he's given up an afternoon of holiday for this.
Thank you, Russell, for doing that. I know that I will come to you in a moment, Rob. I know that a lot of this intelligence from Healthwatch, Brendan and Lucy and Russell, you are aware of, but I'd just ask if that latest report could go to the next Wyatt meeting. I think you've got one next month, even if it's just for information to reiterate what you already know. I think that's really helpful. Okay, I've got a few people that who want to come in, but I'm going to go to Rob first, and Russell, we're aware that we need to ask you questions.
Yeah, I think the quid pro quo is that Brendan gets all the finance questions, as Simon's not here. No, in term, I just wanted to make a quick point on the last contribution from Healthwatch, really, which is what's clearly stated in the report from Wyatt and in the contribution so far is that Wyatt is a collaborative and it's part of the system, and it works closely with people around this table, either in places or at West Yorkshire level. And one of the things that happens very regularly is that people like Claire Smith, who's the Senior Responsible Officer for Urgent Care within Wyatt, meets with Karen, who's the Senior Responsible Officer for Discharge, to make sure that those issues around the interfaces are being picked up, and that Wyatt, being the lead on elective recovery, is developed in such a way that issues around things like the interface, communication with patients, etc., are part of the programme. They're not outside of the programme because they may not always be directly to do with the hospital. So the patient and citizen panel that we've got for people who are waiting is a good example of that. I'm really pleased, Heather, that you've picked up that people's experiences of cancer seem to be more positive. We agreed collectively throughout the pandemic and beyond that we would always prioritise cancer when things were incredibly tight. So to hear some of that feedback's really good, but clearly we need to do a lot more on those 3 C's that you mentioned.
And thank you, Heather, and to Hannah, who you're deputising for today, to continually bringing those 3 areas of communication, compassion and coordination. I think it's really helpful. I can see it in some of the AAA reports in places as well, where I can see our colleague Tim from Leeds saying that your influence is coming through now to remind us of all that. Thank you. So we've got a series of questions or comments from colleagues now. We will be taking note of that. We'll take notes of actions. We'll Lucy and Brendan and Russell, please, I'll take groups of questions and then please come together to respond to those. But also what I have found when we run these sessions, for example, when we ran them with community services in July last year, we end up coming out with some actions as well, a number of us, not just the provider collaborative. So we'll make a note of those. Yeah, for you. Okay, everyone goes home with an action. Thank you. So, well, first we'll hear from Becky, Richard and Fatima. And for particularly people who are watching this meeting, and sometimes we can get up to 300 people watching this on record or live, would you just introduce yourself and remind us who you are on the board? So Becky, then Richard, then Fatima.
Thank you. So Becky Malby, non-executive member. A few points. One, it was really helpful to have you explain that, because it was so much more lively and we felt so much, we got much better sense of the nature of the relationship. So thank you, Lucy, thank you, Russell, thank you, Brendan, for it. But there were some things that didn't come through and I'd really like to hear a little bit more. So the first thing is, I'm absolutely sure the Health Watch report wasn't a surprise to you, but we didn't see that in your paper. So how do you engage with the public? You say you put patients first and patients' views first and what matters to patients first, but I don't know how you do that. I know how you do it around surgical oncology because we've heard about that here and it was a fabulous process. But just systemically, how do you do that? And I think that fits in with the waiting list experience you're talking about, Heather. The guidance around that when we were doing work in my university role 3 or 4 years ago now with the public about what was their experience of waiting and what was problematic are exactly the things that you're still talking about. So are we shifting the dial on that in West Yorkshire at all? So if we are engaging the public, if it is what matters to the public first, if we have got a public voice group on waiting, what's happening? So that's the first question. The second thing is, I suppose, is about fair services for all, which is our a clear remit of this board. Again, Brendan, you were talking about we choose to act where we see variation. I guess, where does that data come from? Because sometimes what you choose to look at is stuff you know or what pops up, and that actually increases variation because we see what we see and we don't see what we don't see. And so some of our people who are easy to ignore are not seen and not getting. And so how would we know if we were meeting those needs at all? So the second one for me is, what data are you using to understand variation and inequalities to help you choose where you're going to act? So that's the second one, because that also links to our BAF and risk. I couldn't see within the paper, I'm going to ask that one is for you, Russell. I couldn't see within the paper where the collaborative is working on our BAF and our risk register. So if we look at the things that I think are very much in your basket, operational pressures that would impact our ability to effectively target resources around children and young people to improve their outcomes, the rationing question, our recruitment questions. So we have a whole set of the BAF and our risk register that we're talking about all the time. I couldn't really see how you're handling that and how that builds into your priority list. And the last thing was you talked an awful lot about learning. Awful lot, and you have that in your strategy. But what's the process by which you systemically learn? So when we're going to later on look at our dashboard, you've painted a really great picture of how fantastically you all learn together, but there are some very significant variations in our dashboard that we'll be coming to. We talked a bit about it this morning. We'll talk a bit about it on the dashboard, where you have got partners who are struggling. I couldn't see how you're doing that. So perhaps just explaining the process by which you identify where you're going to learn and how you do that would be helpful. Thank you.
Thank you, Becky. That's really helpful. I'm making notes as we go along, so I'll try and help for our colleagues from Wyatt to group them. So we'll go on to Richard, then Fatima. Would you introduce yourselves and then we'll come to responses?
Thank you very much. I'm Richard Vorcher. I'm a GP in Leeds, but for this question as well, I'm also declared that I'm the President of the Royal College of GPs. At one of our recent board meetings, we adopted the guidelines, the primary secondary care interface guidelines produced by the Royal College of GPs, which we heard earlier in this meeting have now been adopted in every place, which is really positive. I think my question relates to how we operationalise that, because I think for decades as a GP, I think we've had disconnect between our secondary care services and our primary care services, particularly our GP services, to the disadvantage of patients and also to the disadvantage of professionals who want to engage with one another in a positive and productive way. And we learn from one another when we are meeting together. There are really good examples across West Yorkshire, in Leeds, Bradford and elsewhere, where we've got community-based provision of secondary care style services. And I think you mentioned in your report in 7.2 that the strategy recognises that the work of a hospital trust is no longer confined by the walls of its buildings. And as an integrated care board, we really should take that to our heart. And I think we have real opportunity to develop more secondary care specialist services in the community, with specialists working alongside GPs and other colleagues, building on what works well, ensuring that patients get a good local service. And I'd just like to see a little bit more, or if you explain a bit more about how we can do that, how can operationalise that, and make that a reality, because I think that will be a win-win-win. It will improve professional engagement, it'll improve patient services, and it'll actually improve the interface between primary and secondary care. Yeah.
Thank you, Richard. That's a really helpful question and complements what Heather shared. We'll hear from Fatima and then we'll go to our first set of responses.
It's hello again, everyone. Fatima Khanshaw, West Yorkshire Inclusivity Champion. I have to say, I have got a bit of FOMO about Wyatt now, because you make it sound like a really cool place to be. And yeah, we are the best system in the country, and I'm proud to be a part of it. I suppose I've got a couple of reflections of areas where we could absolutely smash it even further, because why go for average when we could go next level in West Yorkshire, and that's how we roll, isn't it? The first one is about the unwanted variation in waiting well. So we did some really great work during the pandemic, and your trust, Brendan, in particular, led on the inequalities agenda and making some really focused interventions to people who we know are more prone to more adverse health outcomes. And it'd be great to see a little bit more of the so what questions. So we did that, and did it make a difference, and how are we learning from that to make things even better? The second one is about the fact that now we've got a foot in the Mayor's combined authority, going back to Brendan's point about the fact that the people are our community and vice versa. Are we using the leverage of Wyatt in those conversations? So when there are decisions taking place about buses, for example, are we linking up conversations about how we make services more accessible to our communities, but also how we encourage our staff to take alternative routes rather than the cars? And then I suppose my third and fourth area are very much focused on the fact that our people are really tired. We've come out of a COVID pandemic, there's industrial action, and we're heading into some really challenging waters, which means we need to take some really difficult conversations, and our people will be at the forefront of that. So my sort of first reflection is how we supporting a culture for people to speak up on the agenda of quality and safety. And that sort of compassion culture as well, because when you're really tired and you're doing your best and people are still not feeling satisfied, that's a really difficult dynamic. So how do we develop capability to navigate that? And then the final one is about the leadership work that you've done, which is absolutely phenomenal, and to learn a little bit more about where there were some focused interventions in ensuring we're meeting our aspiration of a more diverse leadership, and how we can continue to support that going forward.
Great, thank you. Lots of really helpful points. So there's a point on systematically engaging with the public, tracking use of data and tracking variation and inequalities. How do you systematically learn? How do you have focused interventions on tackling inequalities? How can you work further with WICA, West Yorkshire Combined Authority? That interface between primary and secondary care, moving it from adopted guidelines into actual reality, and bringing more secondary care specialists in the community, and looking after our workforce's health and well-being. There's quite a few there, and I've got a lot more people to come through. So I don't know if maybe one or two of you want to just respond.
I think if we share our strategy and the slide deck, some of these responses will be covered. But I would challenge the scale of some of this speaks to what we described. It isn't about the whole of West Yorkshire or the whole of the White approach in some of this. Some of this speaks to the primacy of place. So I think, what I wouldn't want to assume is that what the people of Leeds need is the same as the people of Kirklees or the same as the people of Calderdale. I think there are commonalities, but that we know, for instance, that there are different areas of health inequalities in each of our places, and that's what we're paying attention to. So a lot of this is covered through the individual organisations, and the learning, I would say, is what's lifted and shifted up across at a Wyatt level. You will see when we share some of the information about some of our structures and how and where this is shared. But I would also ask us all to just look at ourselves about our roles within this. Wyatt is one element of this board. So some of the answers to the questions sit with all of us. So Wyatt is represented in the clinical forum, the workforce forum, the finance and performance forum of this board. It isn't just about us looking at it on the left, it's about us being a core part of this partnership. I think the transport, it's interesting, transport has come up, it's something we are paying attention to. And if I speak to my own organisation, working with the Mail Authority, we have finally got a bus that goes regularly between Calderdale and Kirklees. And it will do phenomenal things for the people of Calderdale and Kirklees. These things, they take time. But the other thing I would say is, if we're going to do something, we try and get it right and do it well. And I think that's an example of how we've done that. I think we haven't probably talked, we didn't have time. We could have gone on all day. But if we think about the health inequalities work and the response to the inequity of access for learning disability patients in an acute setting, we could have talked about that endlessly. But if I remind colleagues, we have heard some of that here before. It's fitting it into the context of the West Yorkshire conversation and how Wyatt plays a part in that. And I would equally, I'd talk again about the health inequalities piece is about what we're seeing now, but it's also about what are we seeing for the future. So I would argue, I'm not sure this answers your point specifically, Richard, but I know that there are patients attending EDs up and down the country with a hypertensive episode who are seen and treated and then discharged. And I think for all secondary care collaboratives and primary care, how do we work together to think about what do we do once those patients are discharged? Because we know they will be accessing services again in 5, 10 or 15 years' time. What we get caught up in, I think, is that's an added or an additional workload for everybody. But if we park that and have the right conversation around the science of our data, then I think that's how we tackle some of the challenges that we're seeing. And I did have another point, but it might have just gone out of my head.
That's okay. We'll come back to you again in a minute.
Let Russell ask a question, because he's off his holiday.
Russell, would you like to respond? And then we're going to go to AC, Majid and Robin.
Yes, thank you. Brendan says, I'll answer the questions and he just answers them all. This is familiar. So I thought I'd give a bit of a worked example because I think it covers a manner of those questions. Because around 3 years ago, we first got together as an elective coordination group. So there's about 4 strands. Elective coordination is one of the strand I lead with Faluki at Airedale. And we got together as a group of clinical and operational leaders, 500,000 patients waiting on a waiting list for a really, really long time, some of them over 2 years. So we kind of sat down and tried to work the problem to understand what it is we could do. So the first thing we looked at was variation. So where were the waits at specific areas at specialty level? Who was doing stuff really well? So as Lucy mentioned, using model system girthed outputs, you can quite clearly see who's doing 11 cataracts on a list compared to 4. So about sharing that best practice and working some of those angles out. And patients where we could move the patients within proximity, we could move the patients. What we agreed to do about two and a half years ago was a wide access policy. So what we realised is people were treating patients differently at different acutes. 1 DNA and you're out, 2 DNAs and you're out. It was all very different. So we looked around the country. We're really humble. We don't get it right all the time. We looked around the country around some of the best practice around using an access policy, which is a vehicle we can all use, and drive out some inequalities through process and working in the same way. So we enabled that. It was signed off with, I think, one of the first collaboratives in the country to have a access-wide collaborative-wide access policy. And what that did is started to drive out some of those long wait variations. Then what we found quite quickly, as Fatima pointed out, that there were some inequalities then that were shining through quite quickly. So we had CHFT, who have done amazing amounts of work, come and present what they were doing in-house. We also went to see Leicester. So Leicester are heralded as a flagship in the country around and what they do on inequality. So we went to see Leicester, what they were doing, and shamelessly stole some of their ideas and actions that were taking place because we knew that was our focus. So we've been working over that the last year, sort of piggybacking CHFT work. And then to answer the question about primary care, we quite realised that as we get down to, we've done loads and loads of the tactical, so we are in a really great place on 65 weeks. We'll be one of the best, considering Leeds being a tertiary centre. We've got really low number of patients we've been working towards. But what we've realised is that this won't we can't stem the demand, so we have to work close with primary care. We have to change some of those models of delivery. We know that Bradford have a fantastic GPSI interactions, and that isn't represented everywhere. So for us, we want to work with our clinical networks that are fairly newly formed, and Professor Briggs did herald as some of the best he'd seen, to work and engage primary care in some of that. So our weekly meetings, we've had PCN leads come and talk to us about the rocks in their shoes, so we can also do something on our side, but also both sides working together collaboratively. So I think we've been on this journey for 3 years in elective. It's probably one of our most advanced sort of working pieces together. And the bit why Brendan I think is valid is there's a radical candour. So we call stuff out. We're not ashamed to say things if they're not right. We're all values-based leaders, but primarily, if one fails, we all fail. So I feel accountable for 500,000 patients in West Yorkshire, and I know Saj, who runs the Cancer Network, feels the same for the cancer patients, and Claire for the UEC patients. So we're bigger than our organisations, and I think that's where we're driving some of that change. But we are data driven, so we are looking at all the data that we have available to us and shamelessly stealing. We've been everywhere. I've been to Bristol, I've been to Newcastle, I've been to Hull. We go everywhere to see what people are doing to bring it back in house. And as Brendan said, that conversely, we've had people come to our meetings to see what we're doing and sort of steal back. So for us, that's kind of where we've been working some of this problem. I think that highlights a couple of those strands of how we do it together, and that's clinical and operational people working together in that space.
Great, thank you very much. That's really, really helpful. And for anyone watching that didn't get any of those acronyms, GIRFT is Get It Right First Time, an NHS initiative. DNA is Did Not Attend, and UEC is Urgent Emergency Care. And I encourage my colleagues just to say them in full because it really helps people watching online. I think Richard, to reiterate your point, I'd encourage our place leads just to take that challenge back and Brendan's reflection there on that interface between primary and secondary care. I know people are working on it every day, every week, but I think that would be something I'd ask our place leads just to say that's a point of discussion coming out of this meeting for place committee consideration. Right, we're going to go on to our next set of comments. We've got AC Majid Robin, then we'll go back to our Wyatt colleagues, West Yorkshire Association of Acute Trusts, and then we've got Rachel Pitt, Tim and Jane, and then we're going to have to finish up this discussion, unfortunately. So AC to you. Would you introduce yourself, AC?
Thanks, Kathy. AC Arunanshu Chatterjee, non-exec member for the board. Thanks, Brendan. Thanks, Russell and Lucy. That was a very comprehensive articulation of the report. I think if it was an election pitch, I would vote for you. I think something that you observed in the paper in terms of a mature collaborative system, I think that's true just having experience of other systems and other collaboratives and other secondary care settings. And that came through in some of the conversations and articulation, again, explaining with examples some of the bits that you shared today. But and I think the discussions that preceded earlier in the morning and some of the things that's coming through, even the Health Watch report constantly, and something that Richard and Becky all sort of shared towards. So we have a joint forward plan, we have a primary care fuller board plan, we have a VCAC plan strategy, and now we have a Wyatt strategy. How does this join up as a sort of system-wide, and how can we improve the interface of the delivery actions within this? So this is less of a question, and I ask, it will be useful to see how these join up. I'm assuming that there is an implementation plan also that's coming through, because of course those pillars are very, very interesting, but it will be useful to see some of those broken down, even at a sort of a very abstract level over the next couple of years. How would you measure success? Of course, you're saying you're moving from previous 5 years. So was that successful, the previous strategy? What worked well, not, and what we can take forward would be useful, specifically if we can look that up against the ICS objectives. And the last bit is sort of looking at, is there a lens of prevention that we can put? Of course, Wyatt is mainly curative, and we are looking at more sort of, but as you said, it's a whole system issue. Can we draw out how over a period of 3 to 5 years against that strategy, we have moved the needle to be a bit more sort of prevention focused, and hence helped the system as a whole?
Thank you. So a continuing theme, I know, AC, you're encouraging us as much as possible to make sure there's that mapping exercise of strategies and plans that connect together, as well as what's worked before, how have we measured that, and how we go forward, as well as a lens of prevention. We'll go to Majid, then Robin, and then we'll come back to Wyatt colleagues.
Yeah, thank you. Really refreshing presentations on built on AC sort of points, then other points that were made earlier on. So first one around research. really pleased that you want to get more involved in research. But in looking at research, it's really important that we make sure that we involve all sections of our community in that research, because there is underrepresentation, and no doubt that will help with our broader work around tackling inequalities. Really pleased with the focus on people. If you can get it right for our people, it'll make it a lot easier to get it right for our communities, because, as you said, our people are our communities and the communities are our people. In terms of leaders and leadership, it'd be good to have a look at what are we looking at in terms of the skills future leaders and leaders of the future will need, and how are they different to what we've got now. And in looking at that, how do we help with the diversity agenda? Because our leadership doesn't reflect our community. So how can we use that momentum to sort of build on that? In terms of the great questions that have been asked around variation, it'd be good to sort of get a feel of how we systematically, as a system, as a collaborative, identify those variations in the first place. Then how do we describe them to the collaborative, so we're all on the sort of same page, putting our sort of energy behind it? And similarly, how we put in our collective efforts together to dismantle them. So it's how we look at the data, how do we sort of come together, and then how do we collectively sort of dismantle them?
Thank you. That's really helpful, and making sure that research is fully informed. We're serving a diverse population, but we're also we're taking care of our diverse workforce, which you talked about in terms of their health and wellbeing earlier, Brendan. And you're building on that comment earlier, Majid, on tackling inequalities, but it's the data, it's the interventions, it's how we're tracking it, and I like your word dismantling. Robin, to you.
Yeah,
Would you introduce yourself?
Yeah, Robin Tudden, I'm the place lead for Calderdale. Just building on one of the points Fatima made, a bit of an offer really. Wyatt comes together around sort of certain things where you can have critical mass and impact at scale, and I think you underplay the potential around health inequalities and health and well-being through being an economic powerhouse together. And I know, CHFT, significant anchor in place, major employer, social value through the reconfiguration work, Health and Skills Academy, the Calderdale College. Your impact at scale is huge, and I think unharnessed in terms of its potential. So I'd sort of an offer to work with you about that with the combined authority. Last week, a big moment, bus reform, franchise, but the other thing, mass transit. So, Leeds and Bradford, so Calderdale, well, what does that mean for us? The one thing that I get that lands in Calderdale is the link to LTHT. Because actually you are a collective presence for people around travel and opportunity in West Yorkshire, and your collective power is a real potential. So to plea that we can do more on that, I think, and make it part of the economic strategy for the whole place, and actually see West Yorkshire as a place in that respect. Not just each of the localities.
That's really welcome. Thank you. Russell, I'll come to you. Do you want to respond on some of those points? And then we're going to go to Rachel, Pip, Tim and Jane and finish up. And Lucy.
I was going back on the variation bit around how do we dismantle some variation, which was a good phrase. I think the work streams that we're working through, we're extremely data driven. So everything in the NHS, especially in the acute, is monitored. We have so much information at our fingertips that's primarily real time. So all of our working groups are set up around what's the data telling us. So in electives, it's obvious. We look at sort of productivity, we look at the throughput, we look at patient experience. We try, we're not doing enough on that, obviously, but we need to do more on the comms and the waiting well piece. UEC, obviously daily reporting. We have mutual aid in place around ambulance diverts, etc., and people under pressure. So I think we're really data driven in those work streams. I think your point is maybe we're quite insular though, and how do we get a wider sort of macro view of some of that data and the impact that data has. So I think I'll take that back personally around what I can do electively on some of the bits. And we've spoken working with Karen previously in the community, and obviously primary care. It was Brian McGregor actually came. He was a standing member of ECG, but elective coordination group. And I think that we could probably do some more on that, but it is at the forefront because it's our litmus test of how we're doing. It's what we use to see if we're good or not. So I think we definitely do that.
Thank you. Lucy, do you want to respond? And then we'll take our final group of comments.
Yeah, so I think just to respond to AC, I think Russell's partly covered this. I think there are a huge number of things that we already measure that can help us almost kind of signal a barometer of where we are and success. Equally, then, I think we've got the opportunity to look at specific programme level measures. So if we talked about aseptics, we talked about non-surgical oncology, there are very specific interventions and associated measures that we can point to say, yes, that has worked, or no, it hasn't. I just wanted to pick up on the prevention point, and just because this is really topical, so Ian and I were looking at each other when you said this, so we're actually starting a piece of work looking at what our opportunities are around secondary prevention. So this is one space where we know that there is a huge evidence base, we know what works, and we know how quickly it can work. So we're in a conversation at the moment with the Improving Population Health team in terms of what we can specifically do in the acute sector around particularly secondary prevention. And just going back to Brendan's point, I think one of the first areas we've recognised is with over 50,000 employees, we've got a kind of captive audience here in terms of what can we do to support the health and well-being of our own workforce. And again, there are specific measures around sickness, absence, that we know we can make an impact on if we start to kind of think of a more holistic way in which we can support individuals' well-being and take a more preventative lens. So something that's fairly new, but quite happy to come back and talk about that once we've done some more detailed work around it.
Just very quickly, I think to your point about the strategy, we haven't done this in isolation. We've done it in consultation with folk, and it plays to the West Yorkshire strategy. So we're part of the delivery arm for this board. I think the other piece, how do we measure success? I think we have a raft of measures that we could talk to you about, but we can't describe 8 years' worth of work in one very short hour. So there's a raft of things that we could talk to you about. And we probably are quite self-flagellating because we go to what we need to improve upon, but actually we do need to talk about what we've done well, because I think that's recognising what our people have done well. I'm all for dismantling the volume of data. So acute trusts are regulated to an inch of their lives. If I talk to you about the performance dashboards that we have to take through our boards, they are on average anywhere between 300 and 600 pages long. So I'm all for dismantling some of that so that we can focus on what we need to focus upon. And then we'll absolutely take an offer of help, but we're there. You know, we're very happy to take any offer of support in how do we grow. But equally, how do we challenge ourselves in the context that we're all operating in to do the right thing and to do it differently? The skills of our leaders was just one point I wanted to raise. That's why we ran the development programme. So we're expecting our leaders to be able to run an acute organisation, which is incredibly complex, extremely detailed. We expect them to understand the mechanics of surgery, the mechanics of an emergency department, everything about a cancer pathway, everything about financial management, and everything about people management. Then we expect them to understand the whole workings of West Yorkshire, the national health picture, what's happening in local government, and what's happening in our people's education and their well-being. So that's why we put this programme on, to say we want to develop our leaders differently, to take the totality of what we expect for these leaders differently. We wanted to enable them to be successful going forward.
Thank you very much. We are short on time, but I don't want to cut short further comments that people have been waiting to make. So we've got Rachel, then Pip, and Tim, then Jane. Would you very briefly introduce yourself as well, particularly for people that are watching? So Rachel, come to you first, then Pip.
Thank you. My name is Rachel Spencer-Henschel, Director of Public Health, representing West Yorkshire on this board. I just want to thank colleagues for the report. Again, won't reiterate what others have said, but it is really, really refreshing, particularly to see that focus on being humble. I think the fact that we won't always get it right and can be honest about that is really important in order to actually not have that blame culture that can sometimes be in sort of big organisations or complex systems. Really support the secondary prevention point because, as you say, from an evidence-based perspective, we know what works, and actually the quicker we can implement that, particularly given the financial situation everybody's in, then I think we can make some real headway. My last point really was sort of alongside Majid really in terms of research. I think we talk a lot about the impact on health and well-being of the pandemic, But I actually think people's fundamental behaviour has changed as a result of that, and that's both our workforce and our populations, and actually how we can understand how that behaviour actually influences the choices that people make, and hopefully result in a better system that responds to that. Because I think although we're still in its early days in terms of understanding the health impacts more kind of longer term, I do think those behavioural changes, and it's become a bit out of fashion talking about behaviour change, but actually I think we should bring it back because it is something that will make a success out of initiative. And then, sorry, very lastly, I just want to shout out to Brendan for the work that we've been looking at around poverty, because I think sometimes the cost of living crisis is affecting everybody, including our staff as well as our population. And sometimes, a bit like the point about transport and travel, how people get to places, even though there might be a clinical justification for something being in a certain place, we need to make sure that we are understanding the impact of poverty. And poverty-proofing initiatives on clinical pathways is something that I think is a really exciting area that can genuinely make a difference. And if we look at our staff as well and their work patterns and poverty-proofing that, we might end up with a much more stable workforce and hopefully a lot less do not attends. Sorry, I nearly went to an acronym then, Cathy. Thank you.
Thank you, Rachel. That's really helpful. Pip, then Tim, then Jane.
Yes, Pip Goff here on behalf of Voluntary Community Social Enterprise Sector. It's a related point for me. We touched earlier, Cathy, you mentioned the Keeping It Local initiative, and I think a lot of all of the conversation we've had is about focusing on people and communities, the economics, trying to line all of these things up to do the right thing for people and communities. So I think there's a huge opportunity. You know, you touched on supply chain, you have that enormous kind of coming together, but also we've got a real opportunity to connect locally. I wanted to just flag the opportunity around waiting well, and it's really good to hear that you're having conversations with national organisations like the Motor Neuron Disease, but you've got a vast array of local third sector organisations who've got huge wealth and knowledge and connections and can really help with so many of these things. So yeah, really, you've obviously done such a brilliant job today because we all want to talk about so many things, so that's brilliant. Just finally, can I just really challenge that language around did not attend? People were not able to access. Nobody chooses not to attend. People struggle for all sorts of reasons. So can we flip that language? I know Children's Services talk about wasn't able to access. So just, I'm sure it's a national target, but it's how we see people at the heart of what we're doing, isn't it?
Pip, that's really helpful. And yes, we report it in a certain way to NHS England. DNA did not attend, but we've had a similar debate around this table, for example, on bed days lost to home or days lost at home when you're looking at discharge from a hospital. So thank you. Tim, then Jane, and then we'll finish up.
Yeah, thank you for the report. I suppose I almost want to flip it around because up to now I think we've been asking you for things. One of the reflections I have working in West Yorkshire, having worked elsewhere previously, but also just reading nationally and hearing nationally, is how positive the relationship with Wyatt has within the place and within West Yorkshire. So I guess my question really is, recognising your contribution and recognising that connection with place and how working alongside colleagues in all our places, I think, from all the trusts has been so positive. It's certainly in comparison to other places. What's working from your perspective, and what would you like? What do you need from us to make this work better?
Thank you, Tim. And we'll hear from Jane and then we'll go back to our Wyatt colleagues. Jane, would you introduce yourself?
Yep, sure. So Jane Madeley, I'm a non-exec member of the board. I think my points probably pick up on a bit of what others have said and some of Tim's point at the end. So I agree with AC. It's a really comprehensive report and there's lots of great stuff within here. I like the strategy, etc. I think it would be nice as a board to make sure going forward that when we have these sessions that we do encourage people to sort of share some of what hasn't gone as well and kind of what we've learnt from that. We've got other collaboratives who haven't had as many years working together in this way, so there are opportunities to learn from some of the sort of things that haven't worked and try not to repeat. And I think we are, as Tim said, keen to hear what what you would ask of us. It felt a little bit light in sort of recommendations or requests. Others have been more forthright, I think, in some of those things. But I think that sort of, not just kind of what we have been doing, but share some of the sort of more challenging stuff with us, so that either, you know, we may be able to help have some new ideas around it, or if not, at least advocate on behalf of, you know, the collaborative in terms of, you know, what would help it work even better than it is today. So just thoughts for, I think, going forward in terms of these sessions. Thank you.
Great, Jane. Thank you, Tim and Jane. It was as though you'd rehearsed that together in asking for the feedback. And you're right, Jane, other collaboratives have been much cheekier with their pitches and proposals. But it has been really helpful. So I think that's something to ask Wyatt colleagues to go back if there's anything we can do. When we heard from primary care colleagues in one of our earlier meetings, they particularly asked us to go back and do some influencing at NHS and England level, for example. So please let us know. I don't know, Lucy, Russell, what are your thoughts there? There's some questions back to you, and then Brendan will come to you to finish up. Lucy.
So I think just on the final point about the ask, I think probably the reason we haven't done that is kind of, as Brendan says, I think we really see ourselves as part of the system and a partner with the ICB, so not coming to ask things of. I think we have those conversations frequently, and I think we feel able to influence. Equally, I think there's a recognition that we have a huge role in terms of how we influence nationally, in terms of what we need to do around acute services. So I think it was probably out of a self-sufficiency rather than not feeling there was anything that we needed to work on further. But absolutely agree with Tim's point in terms of, I think we've done that well. I don't think we always have it cracked in terms of, are we doing the right things at the kind of West Yorkshire collaborative level versus what should we be doing through place. And I think that's something we just need to keep working on, and we need to keep talking to each other to make sure that we get that right.
Russell, final comments from you?
Yeah, just the fact that I think it works really well, as Lucy said, and I think that two-way communication, especially from Rob to us, you know, and giving us the headspace so we can operate in the way that we operate, and also the feedback. You know, we've had some praise from Rob that we've shared with our teams, and that's gone down really well. So I think, you know, you as a board sort of letting us know where problems you face and issues we can tackle, but also if you hear the good stuff, let us know about that as well, because that's really important to the teams.
Great. Brendan.
I think Lucy and Russell have nailed it. I think if I just talk to the DNA point, the do not attend point, I think it's a point well made, but it's a blunt term that actually our regulators understand. But how we're looking at it in Wyatt is there's a health inequality in people not attending. That's where we're paying our attention. We've moved on from just the waiting list to actually it's not just about the elective recovery, it's also about the outpatient level of attendance and what does that mean. But it's probably a blunt tool to have the right conversation. It doesn't meet the needs of our communities, though. I think it's important that we need to pay attention to it. I recognise that. What is the ask? I think Lucy and Russell have nailed it. We deliberately didn't put any asks in because we're a partner of this board. We're not coming and doing we want X, Y, Z, because you would think that we would say we need more money, carve it all off, but everybody around the table needs a different level of income. So we haven't done that. Because I think what I would say in response to this very specific ask, we need more support to be successful. Enable us to be as bureaucratically light as we are. That will keep us as agile as we can be, and it will keep us performing. I think where there is a delivery issue, let Wyatt be involved in the conversation. Let us lead those pieces of work. And it's broader than just fixing somebody's hip or, you know, putting a cardiac valve in. We're bigger and broader than that. That's the conversation we want to have. And all of us have conversations at a national, regional and national level, keep talking about how this collaboration works as an exemplar.
Great, thank you. And you are our longest established provider collaborative. We have other collaboratives at much earlier life stages. It's really helpful how you talked earlier about the Memorandum of Understanding for the Committee in Common. That has been used by two other provider collaboratives to use to reference and adapt. So we recognise that. Thank you, Brendan, because, yeah, you come with an ask if you need to, and less bureaucracy is noted.
We probably wouldn't wait for the board if we had an ask.
No, I know. There you go. That's how established you are. Two things from your report as well. I think if we can then follow up on reduction in carbon emissions on estates, you are our acute colleagues are big estates, and that is something coming through on our climate change strategy that our partnership board looked at earlier this month. We note that the delegation of specialist commissioning is on its way in April next year, which is something probably to come to this board as well as other boards looking ahead together. We note that the Provider Collaborative is having a convention on the 16th of May, which is really welcomed. And thank you for inviting Rob and I to your next meeting at the end of April, which will be really welcome, and we can follow up on this meeting as well. So I hope you all now have a collective and good foundation understanding of what this Provider Collaborative does. It's one of my aims as chair to make sure we've all got that depth of understanding of each of our sectors and services and provider collaboratives across West Yorkshire. And thank you for all you're doing. It's really, really welcomed. And thank you for everyone for their comments around the table. We've noted actions, comments, principles, things to take forward, and we really appreciate that. So we will now pause the meeting in public and take a break, and then for those watching, we will come back in around 10 minutes. Thank you.